Hi guys, this is Ferdinand, and today we'll be talking about dynamic auscultation and splitting of the second heart sound. It's a very high-yield topic for the boards, for class exams, and for step 2 and shelves that you'll be taking during your third year. So we'll spend a little bit of time understanding the basis and the mechanism that causes physiologic changes in his murmurs. So here are the learning objectives for today. So we're focusing on how nitrates, hand grip, face tilt, valsalva, leg raise, and standing from seated position are going to change different types of murmurs. So the aortic stenosis, hokum, mitral regurgitation, and other couple of murmurs that we're talking. And at the end, we'll focus a little bit behind splitting and what diseases can give you different types of splitting that you read in your books. But first, let's talk about different dynamic maneuvers we have. We have hand grip, valsalva, which is specific to the phase 2. There's 4 phases, but what you'll be testing on primarily is a phase 2 of valsalva. Raising a leg or squatting, amyl nitrate, or inspiration. So the key to understanding how these maneuvers are going to affect the murmur changes is to understand how they're going to affect your afterload or your preload. Let's start with inspiration. So inspiration, when you breathe in, your diaphragm is going to move down. So what does that do to your abdominal pressure? It's going to increase your abdominal pressure. But since diaphragm is moving down and your chest is going out when you breathe in, the volume inside your thorax is increasing, which causes your pressure in your thorax to decrease. Now, we all know blood loves to move from higher pressure to a lower pressure. Now, we have a higher pressure in the abdomen and lower pressure in the chest. So, obviously, your bloods want to come back to your chest. And what is in your chest? It's your heart. So the first place that the blood drains to is the right side of the heart. More blood in the right side of the heart, murmurs of the right side will increase because, again, you have more blood, more medium to make noise. Here's a little illustration pointing to the fact that when you breathe in, your pressure here decreases because your volume increases. And I want you to focus here. At the end of your inspiration, your venous return is the highest. That means the highest amount of blood will be in your right atrium, which ultimately drains into your right ventricle. Valsalva maneuver. What does Valsalva do? It's exactly the opposite of inspiration. So Valsalva is breathing out against a closed glottis, right? So you have a closed glottis here and you're trying to breathe out. Your chest pressure is increasing. So it's the opposite. Now you have a higher pressure in your chest than your abdomen and your legs, so blood's not going to want to come back to your right side of your heart. So it'll cause decreased preload and changes in your right-sided murmurs versus left-sided murmurs. Now, we said that there's more blood on your right side murmurs are going to go up. But now you have less blood on the right side, so your right-side murmurs is going to go down, but conversely, your left-sided murmurs is going to go up. Hand grip. Best way to think of hand grip is it just increases the afterload. Increased afterload means increased pressure in the aorta. So blood will want to go through other valves or defects that offer less resistance during systole, right? So if you have defect in your mitral valve, right, that means blood will easily want to go to your left atrium, and your left atrial pressure is around 10 to 15, which is way less than your aortic pressure of 90. And same thing with VSD, which we'll talk about later in this presentation. Amyl nitrate, standing from laying down, they produce the same things. Let's talk about nitrates first. What do nitrates do? They dilate the veins. More dilated the vein, that means more blood stays in the vein. If your blood is staying in the vein, that means it's not coming back to your right atrium. So less blood in the right atrium, ultimately all that blood is going to go to your left ventricle. So you're going to have less blood in your left ventricle at the end of the day. So that's the physiology that you want to think about when you talk about amyl nitrate or standing from laying down. And again, when you stand up, obviously gravity is going to push the blood back to your legs, producing the same effect as amyl nitrate would do. Rapid squatting or leg raise. So this would be the opposite. Remember, when you're squatting rapidly or exercising, or you're using your leg muscles to contract against the veins, right? What would that do? They'll push the blood back to your right side of the heart. So raising the leg has the same effect. So you're laying down, you raise your leg, that means gravity is going to preferentially pull the blood back to your heart. So here's the illustration that proves the point. When you're standing up, you have more blood in your veins versus when you're laying down, it's equal. It's more than here, so you'll have more blood coming back to your right side. So let's talk about murmurs. But before we talk, we got to know where the murmurs are. So the aortic area primarily would be described as second intercostal space on the right. That's the only one they'll talk to you that's on the right side. Pulmonic area, which would be second intercostal space on the left. And then tricuspid, which would be the either fourth or fifth intercostal space, as they'll describe it, or mitral area, which would be the apex area. One thing that I highlighted for you is left sternal border. So when in the boards, you'll see that left sternal border will be used to describe either systolic murmur, systolic ejection murmur, which will signify hypertrophic cardiomyopathy, or holosystolic murmur, and they'll be talking about VSD. And you think about it, your ventricular septal defect, ventricular septum is separating your right and left ventricle, and which will be around here, so you'll hear the murmur preferential on that side. So we have systolic ejection murmurs and holosystolic murmurs. So let's put them in categories. Your systolic ejection murmurs will consist of aortic stenosis, hypertrophic obstructive cardiomyopathy, pulmonic stenosis, and aortic sclerosis. Now, pulmonic stenosis is very rare, and aortic sclerosis produces the same murmurs but doesn't have any outflow obstruction, so we will not be talking about them here. So the high-yield topics here will be aortic stenosis and HOCM. We have holosystolic murmur. That means you hear the same intensity of murmur throughout systole. And we'll be talking about mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. I would try to remember holosystolic because there's not a lot of them. I would remember which ones cause holosystolic, and in that way you could understand which ones cause systolic ejection ones. The first one we'll start talking about is aortic stenosis. So aortic stenosis, you have a defect in your aortic valve. It's stenosed. It's harder to open the aortic valve during systole. It's harder to push the blood during systole. It's going to make noise. Now, it's a systolic ejection murmur. What it means, it's late peaking, so it's diamond shaped. So it's going to start a little bit quieter, become the loudest around the middle, and then decrease in intensity. Versus holosystolic, which will be same intensity throughout. The best way to listen for aortic stenosis murmur would be second intercostal space on the right. So how does a murmur change? So, hand grip, what are you doing to your aortic pressure? We increase the pressure in your aorta, which will make it harder for the blood to go through the aorta already. It was harder to begin with, now you're making it harder. So it'll decrease the intensity of murmur because there's less blood going through. Valsalva or standing up. What do we say Valsalva standing up to? You increase pressure in your thoracic cavity, making it less likely blood to return, or standing up, which will put the blood back into your leg, pull it in your venous system in the leg, because they can accommodate a lot of blood. So that means less blood is in the heart, less blood to make noise for the murmur. So that will decrease it as well. Squatting and leg raise, it's the opposite, right? So you bring in more blood to the heart, then you have more blood going through the aortic valve, so it's going to make louder murmur. HOCM. HOCM is a very, very high yield topic for the boards because dynamic auscultation here, all 5 of them affected slightly differently. So the important thing is, let's look at the normal heart. You have your ventricular septum, and you have your left ventricle here. In HOCM, what happens is your ventricular septum, because of genetic disease, familial, inherited pattern, is going to hypertrophy. Now I want you to take a closer look at the mitral valve leaflet. You see how close it comes here? So this is where you get the murmur. It's obstructive. So these two, decreasing the diameter where your left ventricular outflow tract is, so how the blood is going to go to the aorta, so it produces an obstructive pattern or systolic ejection pattern murmur. And understanding how our dynamic maneuver is going to affect the blood level in your left ventricle will make it easier to understand. So once again, here's this picture, left sternal border. If they're describing it, they're most likely to talk about hypertrophic cardiomyopathy or ventricular septal defect. And we talked about it, that it's a systolic ejection murmur, you're obviously just going to start thinking about hypertrophic cardiomyopathy versus a VSD, which we'll talk about in a bit. So how is all going to affect it? So the mnemonic that I gave you is called Walsh. So I highlighted the first two, V and A, which is Valsalva and amyl nitrate. They will increase the murmur intensity. LSH, which is leg raise, squatting, and hand grip, they will decrease the murmur intensity. So how does that happen? So when you do Valsalva, right, we just said you increase the pressure in your thorax, it's less likely for blood to come through. It means ultimately you're going to have less blood here, Now, if you have less blood here, that means your diameter in your left ventricle is going to be less, right? Because your blood is not pushing the septum and the left ventricular wall apart, right? So that means these guys will be closer together. That means your murmur intensity will increase. Same thing with amyl nitrate. They will dilate the veins in your leg, less blood coming. The diameter here in your left ventricle is going to decrease. These guys will be closer together. The murmur intensity will increase. Now, how about leg raise, squatting, and hand grip? So when you're raising your leg and squatting, what do we say is going to happen to your preload? You're going to bring more blood to your heart, so your preload is going to go up, right? More blood in this left ventricle. That means your septum is going to get pushed this way, and your wall is going to get pushed away because you have more blood, right? Your heart has to accommodate it, which means the space between the mitral valve leaflet and the ventricular septum will increase. Now you have a much bigger hole. That means it's going to make less noise. Same idea with hand grip. So what happens is hand grip, you increase the pressure in your aorta. It's going to be harder to push the blood through to the aorta. That means more blood is going to stay in your heart. Increased diameter, more space between the mitral valve leaflet and the ventricular septum, less loud murmur. All right, now we'll switch gears to holosystolic murmurs. So first we'll start talking about mitral regurgitation. So what is mitral regurgitation? So remember, during systole, the first heart sound you hear is the mitral valve closing. So it's obviously it makes sense, right? You want the blood to go through the aorta instead of the mitral valve. So depending on what kind of pathology you have, in mitral regurgitation, the valve cannot stay closed, or the blood is leaking to your left atrium. The way you'll hear this is you'll hear a holosystolic murmur of the mitral area, which is an apex, is the most likely location that will be described during your examination. So how does it change? Hand grip. So what do you do when you do a hand grip? So increase pressure in the aorta, as we discussed, right? Now, your pressure in your left atrium, what's the magic number we said? It's around 10, right? Pressure in your normal pressure, mean arterial pressure, is 93 in your aorta. Now, if you're doing hand grip, you're increasing that pressure. Where would you want to go? Would you want to go to higher pressure or lower pressure? Obviously, to the lower pressure. So the murmur intensity of mitral regurgitation with the hand grip is going to increase because it's easier to go through the regurgitating valve. Now, let's talk about Valsalva, standing up, and nitrates. So what do? You have decreased preload, right? That means less blood coming back to your left ventricle, right? Less blood here, that means it's just less noise you're going to make when the murmur occurs, right? Because remember, murmurs are a vibration of the blood going through some kind of defect. So if you have less blood, obviously less noise. And then I would just remember those points. Valsalva, standing up, and nitrates, they all decrease preload, so they produce the same effect. Talk about tricuspid regurgitation, which is another holosystolic murmur. So it's the same dynamic changes as you'll see in mitral regurgitation. But what will happen, right? How are you going to differentiate between mitral regurgitation and tricuspid? So remember, tricuspid valve is on the right side of your heart. And what do we say? Inspiration is ultimately going to bring more blood to the right side of your heart. So right-sided murmurs are going to get louder. So best way to differentiate that is exam will present you with a case that murmur gets louder during inspiration. Last but not least, we're going to talk about ventricular septal defect. In ventricular septal defect, instead of a normal septum here that separates the left ventricle and right ventricle, you have this defect or a hole that allows the blood to go through the right ventricle. Now remember, your pressure in your right ventricles is way lower than your left ventricle, so it would be a lot easier for the blood to go to the right ventricle. So how would it change? So increase afterload. Now, if you have increased pressure in our aorta, right, where would blood want to go? It's going to want to go to your right ventricle, so your murmur intensity will increase. How about Valsalva, standing up, or nitrates? What do we say they do? They decrease preload, right? You have less blood coming to your right ventricle, which ultimately is going to go to the pulmonic artery, pulmonic veins, and come back to your left side of your heart. Now you have less blood coming in. That means you'll have less blood going back through the defect. Your murmur intensity will decrease. And a squatting leg raise is going to do the opposite. More blood coming in, more blood in the left ventricle, more blood to make noise or increase the intensity of the murmur. All right. Here's a little chart that kind of goes through different maneuvers and how you could differentiate different murmurs. It follows the same ideas that we talked about at the beginning of the presentation with each type of murmurs. So you could go through it, try to test yourself, cover one side or the other, and try to get to the answer. Splitting. So what is splitting? Splitting, when it refers in heart sounds, means the splitting of the second heart sound. Your second heart sound has two components, the aortic valve closure component and the pulmonic valve closure. So during inspiration, you hear the splitting. What does that mean? That means your aortic valve closes before your pulmonic valve, or your pulmonic valve closes before your aortic valve, whichever way you want to remember it. So why does that happen? So what do we say happens during inspiration? Your thoracic pressure decreases, right? So it's easier for blood to come back to your right side of your heart. Goes to the right atrium, goes to the right ventricle. Now you have more blood, right? All that blood has to go through the pulmonic valve. And it takes the pulmonic valve to close later because it has to accommodate much more blood this time. But during expiration, it's the opposite, right? So they close around the same time. So remember this diagram we went over again? So the whole point is your venous return is the highest during your inspiration. More blood, that means pulmonic valve will close later because it has to accommodate much more blood that's in your right ventricle. The analogy that I like to use with this is the bus. So let's say you're here during the summer, there's not a lot of undergrads, right? There's going to be a lot less people in the bus. So the bus doors, when you leave, it's going to close earlier, right? Now, end of August, beginning of September, all these undergrads come in, they'll flood the buses. What's going to happen? So bus doors have to open longer, right, for those undergrads to go through, right? And that means it'll close later, and you'll hear the noise a little bit later than the aortic valve noise. All right, so here, different kind of splitters that we'll talk about. We'll talk about white splitting, fixed splitting, and paradoxical splitting, and where you would see them. So let's talk about white splitting first. So what does white splitting mean, and what does it signify? So what it signifies is your right ventricle is emptying later, or it's delaying its emptying, right? The two diseases that you should know is pulmonic stenosis or right bundle branch block. So during pulmonic stenosis, right, it's harder for your right ventricle to push the blood through the pulmonic valve because it's stenosed, right? So that means it's going to take even longer for the blood to go through the pulmonic valve. Remember what we say during expiration, you pretty much don't hear the splitting, right? And then you hear it during inspiration. Now, in white splitting, you'll hear it during expiration, and it's going to get even louder during inspiration because you have more blood coming through, and it's way harder to push the blood through. Same idea with right bundle branch block. So instead of stenosed valve, you have a conduction defect in your right bundle, right, in your right ventricle. So it'll take longer for right ventricle to contract, so it'll take longer for the blood to go through. So the key point is your pulmonic valve will close later than usual. And you'll hear splitting during expiration, right? Because your pulmonic valve, your right ventricle is taking longer to eject the blood, and here it's just going to get even louder because more blood is coming back to your right ventricle. How about fixed splitting? I would remember fixed splitting is a very high yield topic. And when they say fixed splitting, the first thing that should come to your mind is ASD. So what happens? Fixed splitting means you have same timing between the A2 and P2 during expiration and inspiration. Remember, atrial septal defect, or ASD, means you have a septal defect between left atrium and right atrium. So blood will preferentially want to go to the right atrium because the pressure in the left atrium is higher, right? You have fixed amount of blood coming in through all the time. So then your splitting stays fixed because you're not changing the blood volume. Paradoxical splitting. So what's paradoxical splitting? So we said usually aortic valve closes before the pulmonic valve. So what happens here, your aortic valve closes actually later than your pulmonic valve. So what would cause that? So first of all, aortic stenosis. Same idea as pulmonic stenosis as we talked before. Here, now you have to take longer to push the blood through the aorta. Or left bundle branch block. Same idea as right bundle branch block, but your left ventricle conduction has a defect in it, right? So it takes longer for the left ventricle to contract. That means it takes longer for that blood to go through the aorta, right? So the point is, right? So if you take a look at it during expiration, right? your aortic valve closes later, right? Because your pulmonic valve closes normal time, but we said the aorta has a defect here, or your left ventricle is not pumping as much blood, so it's just going to take longer for the aortic valve to close. What happens during inspiration? So what do we say? During inspiration, you have more blood coming to the right side of your heart. So your pulmonic valve is actually catching up with your aortic valve here. So that's why you don't hear the splitting during inspiration, but you hear it during expiration. All right, so summary. So what did we talk about today? We talked about different dynamic auscultation techniques and their effects on the murmurs that we talked about, and different types of splitting and which disease states you would see. All right, so that should be it. Hopefully you enjoyed the topic. Hopefully you use it for your board studying or the future references. And if you have any questions, please let us know.